Welcome to the Doc Scenario Challenge, Season 1, Episode 1, focusing on pediatric cases. In this episode, we will explore a clinical scenario involving a patient presenting with significant respiratory distress and laboratory findings indicative of severe anemia. Today's clinical case involves a pediatric patient who presents with respiratory distress. A chest radiograph shows an infiltrate, and the laboratory results reveal a hemoglobin level of 5 grams per deciliter, a hematocrit of 16%, and a white blood cell count of 30,000 per microliter. The arterial blood gas analysis indicates a pH of 7.21, a partial pressure of carbon dioxide of 35 mmHg, and a bicarbonate level of 15 mg per liter. Given this information, I will ask Nimwa Blisloff-Wendo a few questions to assess his understanding of the case. Nimwa, based on the clinical presentation and laboratory findings, can you identify 2 likely organisms that could be responsible for this patient's condition? This question is worth 2 marks.
The 2 likely organisms that could be causative in this clinical picture are Streptococcus pneumoniae and Haemophilus influenza. These organisms are commonly associated with pneumonia and can lead to respiratory distress in patients, particularly those with functional asplenia.
Thank you, Nimwa. Now, I would like you to provide 2 components of the differential white blood cell count that may be elevated in this scenario, along with reasons for the expected increases. This question is worth 4 marks.
The first component is lymphocytosis, which is likely due to functional asplenia. The spleen plays a crucial role in filtering blood and mounting an immune response, and when it is not functioning correctly, there can be an increased production of lymphocytes. The second component is neutrophilia, which is indicative of a bacterial infection. The elevated neutrophil count suggests that the body is responding to the infection, particularly in the case of pneumonia where bacteria are often the causative agents.
Excellent, Nimwa. Lastly, what derangement do the arterial blood gas values indicate in this patient? Please explain your reasoning. This question is worth 4 marks.
The arterial blood gas values indicate metabolic acidosis with partial respiratory compensation. The low pH of 7.21 signifies acidemia, and the low bicarbonate level of 15 mg per liter indicates a primary metabolic acidosis. Furthermore, the low partial pressure of carbon dioxide at 28 mm of mercury suggests that the body is attempting to compensate for the acidosis by increasing ventilation to blow off carbon dioxide, which reflects a partial respiratory compensation.
Thank you, Nimwa Blisloff-Wendo, for your insightful answers. This case highlights the importance of recognizing the signs of severe anemia and respiratory distress in pediatric patients, along with the role of laboratory findings in guiding diagnosis and management. Stay tuned for more episodes in the Doc Scenario Challenge, where we continue to explore important medical scenarios in pediatrics. Welcome to Season 1, Episode 2 of the Paediatrics Doc Scenario Challenge. Today, we will discuss a case involving a 2-year-old boy named Muno. Our student, Rogers, will walk us through this clinical scenario, including his examination findings and management plans. Let us begin. Muno is a 2-year-old boy who presents with a 2-week history of diarrhea, poor feeding, and fever. He was admitted to the hospital and noted to have some skin discoloration and hair changes. His mother suspects that he has lost some weight. On examination, he has crepitations in the chest and hepatomegaly. His weight is recorded at 2.8 kilograms, and he is 82 centimeters tall. Now, Rogers, besides weight and height measurement, name 2 bedside examinations you would perform that would assist in determining the diagnosis, along with the likely findings. 2 marks.
Thank you, Doc Scenario. The 2 bedside examinations I would perform are 1. Mid-upper arm circumference (MUAC). A MUAC measurement of less than 11.5 centimeters would indicate severe acute malnutrition. 2. Fundoscopy. During the fundoscopy, I would look for features such as Bitot spots, which are indicative of vitamin A deficiency, and could show conjunctival clouding or ulceration.
Excellent, Rogers. Now, what is the nutritional status of Muno based on the information provided? Use the Z-score chart provided in the case. 2 marks.
Based on the weight for height Z-score chart, Muno's nutritional status is classified as severe acute malnutrition.
You discover that Muno is in shock. Outline your management plan for this child. 4 marks.
In managing Muno, I would take the following steps. 1. Administer supplemental oxygen to ensure adequate oxygenation. Point 2. Provide intravenous glucose at a dosage of 5 ml per kilogram stat to address hypoglycemia. Point 3. Initiate intravenous fluid therapy using half-strength Darrow solution in 5% dextrose at a rate of 15 ml per kilogram per hour to rehydrate the patient. Point 4. Ensure that Muno is kept warm to prevent hypothermia.
After conducting several investigations, you discover that Muno has 2 chronic infections. Name the 2 most likely infections prevalent in our setting. 2 marks.
The 2 most likely chronic infections that Muno may have are 1. Tuberculosis (TB), 2. Human immunodeficiency virus (HIV).
Thank you, Rogers, for your insightful responses. This case highlights the importance of thorough clinical assessment and timely management in pediatric patients. We appreciate your participation in this episode of the Paediatrics Doc Scenario Challenge. Join us next time for another engaging clinical scenario. Welcome to Season 1, Episode 3 of the Paediatrics Doc Scenario Challenge. In this episode, we will explore an important case involving acute poisoning in an adolescent patient. The scenario we will discuss today highlights the critical nature of recognizing toxic syndromes and the appropriate management strategies. Let us dive into the case. An adolescent female named Ramona has been wheeled into the emergency room. She recently received her G12 examination results, which were poor, and her father expressed his disappointment with her. Her mother is concerned and suspects that Ramona may have ingested a harmful substance, as she has been crying for the past 2 days. During the primary survey, you discover that Ramona has a Glasgow Coma Scale score of 9 out of 15, her pupils are pinpoint, and she is diaphoretic. Her heart rate is 58 beats per minute, and her blood pressure is 80/48. To begin with, can you explain what a toxidrome is? This question is worth 2 marks.
A toxidrome is a syndrome characterized by a specific set of clinical signs and symptoms that are associated with a particular type of poisoning. Identifying a toxidrome can assist clinicians in diagnosing and managing cases of suspected poisoning.
Excellent. Now, can you list the clinical features that indicate someone has taken a toxic substance? This question is also worth 2 marks.
The clinical features that may indicate toxic substance ingestion can include altered mental status, changes in vital signs, pupil size alterations, diaphoresis, and specific neurological symptoms. Each toxidrome has distinct features that can aid in diagnosis.
Based on the primary survey findings, what is the most likely type of poisoning that Ramona is experiencing? This question is worth 2 marks.
Given Ramona's presentation, particularly her Glasgow Coma Scale score of 9, pinpoint pupils, diaphoresis, bradycardia with a heart rate of 58 beats per minute, and hypotension with a blood pressure of 80/48, this clinical picture is most consistent with organophosphate poisoning.
Well done. Could you explain the basic biochemical changes that lead to this state? This question carries 3 marks.
In organophosphate poisoning, there is stimulation of acetylcholine receptors due to the inhibition of acetylcholinesterase. This leads to excessive parasympathetic activity and results in the activation of peripheral nicotinic and muscarinic receptors, causing the clinical symptoms associated with this toxidrome. A helpful mnemonic for these symptoms is DUMBELS, which stands for diarrhea, urination, meiosis, bronchospasm, emesis, lacrimation, and salivation.
Finally, what would be your management approach for Ramona? This question is worth 3 marks.
My management approach would begin with activating the Advanced Trauma Life Support Protocol to ensure that Ramona is stabilized. I would administer atropine to counteract the muscarinic effects of organophosphate poisoning and pralidoximate to reverse the binding of the organophosphate to the enzyme acetylcholinesterase. This combined approach is critical in treating the symptoms and addressing the underlying toxicity.
Thank you, Namwa Blislaf-Wendo, for your thorough answers and insights. You have effectively demonstrated an understanding of the management of acute poisoning in adolescents. This concludes our case discussion for today. Join us next time for another episode of the Paediatrics Doc Scenario Challenge. Welcome to Season 1, Episode 4 of the Paediatrics Doc Scenario Challenge. In this episode, we will discuss a clinical case involving a 12-year-old patient who presents with serious symptoms. Our participant today is Rogers, a medical student who will help us explore the diagnostic and management aspects of this case. Let us get started. Today, we have Molly, a 12-year-old girl who has been wheeled into the emergency room at the University Teaching Hospital after a 3-day history of headache, fever, and vomiting. On examination, she is drowsy, has a temperature of 39.8 degrees Celsius, and you note the presence of a non-blanching pedicule rash covering her entire body. During the assessment, she starts to convulse. Rogers, based on this presentation, what is your most likely diagnosis? This is worth 2 marks.
The most likely diagnosis in this case is meningococcal meningitis.
Correct, that is indeed meningococcal meningitis. Now, besides what has already been mentioned in the scenario, can you name 4 additional clinical signs that may be elicited in Molly? This is worth 2 marks.
Yes, the 4 clinical signs that may be elicited are 1. Brudzinski's sign, 2. Koenig's sign, 3. Babinski's sign, 4. Neck stiffness.
Excellent. Now, let's move on to investigations. What 3 investigations would you order for Molly? This question is worth 3 marks.
I would order the following investigations. 1. A lumbar puncture. 2. An electroencephalogram. 3. A full blood count, along with blood culture and sensitivity testing, and a clotting profile.
Good answers. Next, can you describe the microscopic appearance of the organism that is likely to be isolated in this case? This is worth 1 mark.
The microscopic appearance of the organism isolated would show diplococci that are non-motile, non-spore-forming, and encapsulated bacteria.
Well done. Finally, can you name 2 potential complications that Molly may experience besides the ones we have already discussed? This question is worth 2 marks.
2 possible complications are 1. Hypoglycemia, 2. Cranial nerve palsies.
Excellent. Now, for the long-term effects, what would be 2 possible complications Molly may face? This is also worth 2 marks.
2 long-term complications could include 1. Acquired brain injury, 2. Hearing impairment.
Thank you, Rogers, for your insightful responses. This case highlights the importance of recognizing the signs and symptoms of meningococcal meningitis in pediatric patients. Understanding the potential complications and appropriate investigations is crucial in managing such cases effectively. Thank you for watching Season 1, Episode 4 of the Paediatrics Doc Scenario Challenge. We hope you found this discussion informative. Stay tuned for more episodes. Welcome to Season 1, Episode 5 of the Paediatrics Doc Scenario Challenge. In this episode, we will be exploring a clinical case involving a young child presenting with respiratory symptoms and systemic findings. Join us as we delve into the details of this case and discuss the appropriate diagnostic approach and management strategies.
Let me present the case to you. Melita is a 3-year-old boy who presents with a 2-week history of cough and fever that has proven unresponsive to intravenous antibiotics. Upon admission, he was noted to have rapid breathing and chest indrawing on day 7, with the mother reporting that he has lost some weight. On examination, he has crepitations in the chest and hepatomegaly. His weight is recorded at 12.3 kilograms, and his height is 94 centimeters tall. Based on this presentation, what is the most likely diagnosis? 2 marks.
The most likely diagnosis is disseminated tuberculosis. Excellent. Now, what investigations would you order to aid in confirming this diagnosis? 3 marks.
I would order the following investigations: gastric lavage for genexpert testing, acid-fast bacilli smear and culture, stool microscopy and culture, a full blood count, liver function tests, renal function tests, arterial blood gases, urea and creatinine levels, chest X-ray, and abdominal ultrasound.
Good approach. Your preliminary investigations do not yield significant results. You decide to perform a urine test. What is the name of the test you would conduct? 2 marks.
The test I would perform is urine lipoarabinomenon.
That is correct. Now, suppose you perform a lymph node biopsy. Can you describe 2 histopathological appearances that you would expect to see? 2 marks.
In the lymph node biopsy, I would expect to see cass-eating epithelioid cells and giant cells, along with the presence of histiocytes and lymphocytes.
2 weeks after commencing treatment, the child develops jaundice. Considering the medications, which drug is most likely responsible for this adverse reaction? 1 mark.
The drug most likely responsible for the jaundice is pyrazinamide.
Thank you, Rogers, for your thorough responses. This case highlights the complexities of diagnosing and managing disseminated tuberculosis in pediatric patients. Join us next time for more engaging clinical scenarios in our Paediatrics Doc Scenario Challenge. Welcome to Season 1, Episode 6 of the Paediatrics Doc Scenario Challenge. In today's episode, we will explore key definitions related to nephrotic syndrome. Nephrotic syndrome is a clinical condition characterized by significant proteinuria, hypoalbuminemia, and edema. Understanding the different classifications and responses to treatment is crucial for effective management. Let us delve into the specific definitions of remission, steroid sensitivity, steroid resistance, steroid dependence, and frequently relapsing nephrotic syndrome. Imagine a patient, a young child diagnosed with nephrotic syndrome. After initiating steroid therapy, the healthcare team closely monitors the child's response to treatment. Throughout this case, we will examine how the definitions apply in clinical practice. Let us start with the first question. What does remission mean in the context of nephrotic syndrome? 2 marks.
Remission refers to the cessation of steroid medication without the recurrence of nephrotic syndrome. It is typically defined as having trace or no protein in the urine for 3 consecutive days after completing the therapy.
Excellent. Now, could you explain what is meant by steroid-sensitive in nephrotic syndrome? 2 marks, ***.
Steroid-sensitive denotes a patient who achieves complete remission within the first 28 days following the initiation of steroid therapy. This indicates a favorable response to the treatment.
Good explanation. Now, what does steroid-resistant mean? 2 marks, ***.
Steroid-resistant refers to patients who do not achieve remission despite undergoing steroid therapy. This suggests a lack of responsiveness to the medication and often requires further evaluation and alternative treatment options.
Very well stated. Moving on, can you define steroid-dependent? 2 marks, ***.
Steroid-dependent patients are those who experience a relapse while on steroid therapy or within 14 days after completing the steroid treatment. This indicates that their condition is not adequately controlled by steroids alone.
Excellent. Finally, please explain what is meant by frequently relapsing nephrotic syndrome. 2 marks, ***.
Frequently relapsing nephrotic syndrome refers to patients who experience relapses 2 or more times within the first 6 months of treatment or 4 times within 1 year. This necessitates careful monitoring and potential adjustments in management strategies.
Thank you, Rogers, for providing clear and concise answers regarding these important definitions related to nephrotic syndrome. Understanding these concepts is crucial for pediatric practitioners to effectively manage patients with this condition.
Thank you, Doc. It is essential for all healthcare providers to be familiar with these definitions to ensure optimal care for our patients.
Thank you for joining us in Season 1, Episode 6 of the Paediatrics Doc Scenario Challenge. We hope you found this discussion informative. Be sure to tune in for our next episode as we continue to explore more pediatric topics. Welcome to Season 1, Episode 7 of the Paediatrics Doc Scenario Challenge. In today's episode, we will discuss a complex pediatric case involving a 7-month-old infant presenting with respiratory distress and failure to thrive. We will explore the clinical findings, diagnosis, management approach, and potential complications. Let's dive into the case. Today, we have Mavuto, a 7-month-old infant who presents with a cough and difficulty breathing. His current weight is 4.5 kilograms. Having been born at a term weight of 3 kilograms. This is the 3rd time Mavuto has been admitted to the hospital with similar symptoms. Upon further questioning, we discover that he does not suckle well and frequently stops to catch his breath. Additionally, he experiences excessive sweating while feeding. On examination, Mavuto appears malnourished and is in obvious respiratory distress. He is pale but not cyanist and displays tachycardia. Auscultation reveals loud S1 and S2 heart sounds along with a murmur. Notably, There is a palpable liver 3 centimeters below the right costal margin. A cardiac echocardiogram shows a ventricular septal defect. Rogers, let us begin with the first question. Describe fully the murmur that you heard in this patient. This question carries 3 marks.
The murmur I would describe is as follows. In the tricuspid area, there is a harsh holosystolic murmur. This type of murmur occurs throughout the entire systole and is typically associated with ventricular septal defects due to the high pressure flow from the left ventricle to the right ventricle. In the mitral area, there is a mid-diastolic murmur. This murmur arises due to increased blood flow across the mitral valve during diastole, often seen in patients with increased pulmonary blood flow, which is characteristic of left to right shunts such as in the case of ventricular septal defect.
Excellent, Rogers. Now, can you provide the full diagnosis for Mavuto? This question is worth 2 marks.
The full diagnosis for Mavuto is a cyanotic heart disease secondary to a ventricular septal defect, complicated by malnutrition and anemia.
Well done, Rogers. Next, outline your approach to the management of this infant. This question carries 3 marks.
My management approach for Mavuto would include the following steps. 1. Admit the patient to the hospital for close monitoring and management of his condition. 2. Treat malnutrition through nutritional support, ensuring that Mavuto receives adequate calories and nutrients to promote weight gain and growth. 3. Address anemia by conducting appropriate investigations and administering necessary interventions, which may include iron supplementation or transfusions as indicated. Additionally, I would counsel the parents regarding Mavuto's condition and discuss the potential need for surgical intervention to repair the ventricular septal defect once he is stable.
Thank you, Rogers. Lastly, can you explain what Eisenmenger syndrome is? This question is worth 2 marks.
Eisenmenger syndrome is a condition that arises as a complication of long-standing untreated congenital heart defects that cause a left-to-right shunt, such as ventricular septal defect. Over time, the increased pulmonary blood flow leads to pulmonary hypertension. If this condition persists, it causes the pressure in the right ventricle to exceed that of the left ventricle, resulting in a reversal of the shunt. Consequently, this leads to cyanotic heart disease characterized by decreased oxygenation of blood and systemic desaturation.
Thank you for your detailed responses, Rogers. This case illustrates the importance of recognizing and managing congenital heart defects in pediatric patients. We hope this discussion has provided valuable insights into pediatric cardiology. Join us next time for more exciting cases in the Paediatrics Doc Scenario Challenge. Welcome to Season 1, Episode 8 of the Paediatrics Doc Scenario Challenge. In today's episode, we will be discussing a critical case involving a neonate. Let's delve into the scenario and see how our student, Rogers, handles the situation. Today, we have a 4-day-old neonate admitted with fast breathing and difficulty feeding over the past 2 days. This infant was born by spontaneous vaginal delivery and cried at birth. Upon examination, the infant weighs 2.750 kilograms and has a distended, but soft abdomen with present bowel sounds, which appears somewhat sluggish. The last bowel movement was 6 hours ago, and the skin shows mottling. Now, let us begin with the first question. What is your most likely diagnosis for this condition? 2 marks.
The most likely diagnosis for this condition is necrotizing enterocolitis. Marks, 2.
Excellent, Rogers. Now, what does the mottling of the skin suggest to you? 2 marks.
The mottling of the skin indicates reduced vascular perfusion, often associated with circulatory compromise or shock. Marks, 2.
Very good. Now, please list 2 risk factors associated with necrotizing enterocolitis. 2 marks.
The 2 risk factors for necrotizing enterocolitis are prematurity and formula feeding. Marks, 2.
Well done, Rogers. Finally, please outline 4 relevant investigations you would carry out to further diagnose this condition. 4 marks.
The 4 relevant investigations I would conduct include 1. Abdominal X-ray or ultrasound to assess for bowel distension or perforation. 2. Blood culture to check for potential infections. 3. Erythrocyte sedimentation rate and C-reactive protein to evaluate for inflammation. 4. Full blood count with differential count to assess for leukocytosis or other hematological abnormalities. Marks, 4.
Excellent work, Rogers. You have effectively identified the diagnosis, discussed the implications of skin mottling, outlined key risk factors, and suggested relevant investigations. Thank you for joining us in this episode of the Paediatrics Doc Scenario Challenge. Until next time, keep learning and stay curious. Welcome to the Doc Scenario Video Challenge, Season 1, Episode 9. Today's case centers on a young patient with unique health concerns. Joining me is Rogers, our medical student, who will be working through the case with us. Rogers, let's dive into today's scenario. We have a 4-month-old infant named Muhammad, who was born to a 39-year-old mother. Muhammad is brought to the outpatient department with a history of easy fatigue and sweating while breastfeeding. His birth weight was 3 kilograms, and his current weight is 4.5 kilograms. Upon physical examination, the child shows signs of facial dysmorphism, and a heart murmur is detected. Rogers, let's start with some questions. What is the most likely genetic condition Muhammad has? This is worth 3 marks.
Given Muhammad's presentation of easy fatigue and sweating during breastfeeding, along with facial dysmorphic features and a heart murmur, the most likely genetic condition is trisomy 21, also known as Down syndrome.
Excellent. Next, describe 4 dysmorphic facial and head features you would expect to see in this patient. This question is worth 2 marks.
In a child with trisomy 21, I would expect to see the following dysmorphic features on the face and head. 1. Upward slanting palpebral fissures. 2. A flat nasal bridge. 3. Low set ears. 4. Macroglossia, or an enlarged tongue. Other features might include microstomia, epicanthal folds, and hypertelorism, which refers to widely spaced eyes.
Very thorough, Rogers. Now, moving on to congenital heart abnormalities. Name 2 possible congenital heart lesions commonly associated with this condition. This question is worth 4 marks.
The 2 congenital heart lesions commonly seen in trisomy 21 patients include 1. Atrioventricular septal defect, also referred to as an endocardial cushion defect. 2. Ventricular septal defect. Additionally, an atrial septal defect is also a possible lesion in these patients.
Well done. Now, our final question, what would you expect the hemoglobin level to be in this patient, and why? This question is worth 1 mark.
I would expect Muhammad's hemoglobin level to be low. Children with trisomy 21 are at increased risk of iron deficiency anemia, which could result from nutritional challenges and feeding difficulties, both common in patients with this condition.
Thank you, Rogers. That was an excellent breakdown of this case. You highlighted the essential features of trisomy 21 and connected it well with Muhammad's symptoms and clinical findings. Thank you to everyone for tuning into Season 1, Episode 9 of the Doc Scenario Video Challenge. We hope you found this discussion insightful, and we'll see you in the next episode. Welcome to Season 1, Episode 10 of the Paediatrics Doc Scenario Challenge. In today's episode, we will explore the nutritional needs of children and the specific vitamin and mineral supplements required in various clinical situations. Joining me is Rogers, a medical student eager to discuss these important topics. Let us begin with the scenario. A 7-year-old child presents with recurrent infections, lethargy, and poor growth. Upon assessment, the child's diet appears normal, but there are concerns regarding specific nutrient deficiencies. Based on the information provided, we will match clinical situations with appropriate supplements. I will pose a series of clinical scenarios, and I would like you, Rogers, to provide the corresponding supplements based on your knowledge. First, we have a child with liver disease. What vitamin or supplement would you recommend in this situation, and why? 2 marks.
In the case of a child with liver disease, I would recommend all fat-soluble vitamins. Liver dysfunction can impair the absorption and metabolism of these vitamins, which are crucial for various bodily functions, including immune response and blood clotting.
Next, consider a pregnant teenager undergoing isoniazid therapy. What supplements should be provided? 1 mark.
For a pregnant teenager on isoniazid therapy, I would recommend pyridoxine. Isoniazid can interfere with vitamin B6 metabolism, leading to a deficiency that can negatively impact both maternal and fetal health.
Now, let us discuss a child who has been admitted due to phenytoin therapy. Which supplement is indicated in this case? 1 mark.
The recommended supplement for a child receiving phenytoin therapy is vitamin D. Phenytoin can affect vitamin D metabolism and lead to deficiencies, increasing the risk of bone-related complications.
Consider a child suffering from measles in a developing country. What vitamin should be administered? 1 mark.
In a child with measles, particularly in a developing country, vitamin A supplementation is crucial. It can help reduce the risk of severe complications and mortality associated with measles.
Now, let's address a 14-year-old female with polymenorrhea. Which supplement is appropriate here? 1 mark.
For a 14-year-old female experiencing polymenorrhea, iron supplementation is recommended. Menorrhagia can lead to iron deficiency anemia, which is common in this demographic.
Next, we have a breastfed infant in Alaska. What vitamin should this infant receive? 1 mark.
A breastfed infant in Alaska should receive vitamin D supplementation. Due to limited sunlight exposure, infants may not receive adequate vitamin D for healthy bone development.
For a child with sickle cell disease, what supplement would you recommend? 1 mark.
For a child with sickle cell disease, I would recommend folate supplementation. Increased folate is necessary for proper red blood cell production and to help prevent anemia.
What supplement is crucial for a 1-day-old newborn? 1 mark.
A 1-day-old newborn should receive vitamin K. This is essential to prevent vitamin K deficiency bleeding, a serious condition that can lead to hemorrhagic disease in newborns.
What supplement would be indicated for a 6-month-old on replacement feeds? 1 mark.
For a 6-month-old on replacement feeds, iron supplementation is advisable. At this age, infants may require additional iron due to increased demands as they grow.
Finally, what is the recommended supplement for a child with tetralogy of Fallot, who experiences frequent TET spells? 1 mark.
In the case of a child with tetralogy of Fallot experiencing frequent TET spells, iron supplementation is important due to the increased risk of iron deficiency related to chronic hypoxia and increased red blood cell turnover.
Thank you, Rogers, for your insightful answers and for participating in today's episode of the Paediatrics Doc Scenario Challenge. Understanding the specific vitamin and mineral needs of children in different clinical situations is crucial for effective management and prevention of deficiencies. Join us next time for another engaging discussion.